Dr. Kenrick Duru, who is a professor in the Division of General Internal Medicine and Health Services Researcher, and one of the leadership team members from the get-go for the last 2 years working on this.
Great. So thank you, Catherine, Eric. Thank you, everyone who really put this day together. I'm feeling very energized. It was a tremendous morning. I thought we had a great panel and a really inspirational keynote address, really framing the big picture, but also what the evidence is, where it needs to be improved, and examples from another health system on how we can move forward. So before I start, I wanted to say that John Moffitt and I did not coordinate our outfits last night, I promise you, to be matching moderators. I call him my friend, but we pick our clothes independently. So this was entirely coincidental. But so I think I'm going to call the panelists forward in a minute or two, but wanted to just remind us what Catherine said starting out, that we hope this isn't a one-off event. And so I think we had a great introduction, but I'd like to focus this afternoon and then in the wrap-up, really thinking about how we can move this forward. What are the next steps, both in terms of research, this is implementation, dissemination. What are the next steps in each of our health systems to really advance the dialogue and be a leader as we move inevitably forward towards providing better value to our patients. So I think if the 4 panelists, I think I see them here, could come and have a seat, I'll introduce them and we'll start. And while they're walking up, I'll say it'll be the same format as earlier. We'll ask each of them to speak for about 2 minutes on their work and then maybe another 2 or 3 minutes on, again, what they see as the next steps based on their experience in their work. And then maybe we'll have a few questions here and then open it up to the audience. And we have the same 2 microphones on the side. And we'll try to get as many views as we can before we are told to close. All right, so I think what I'll do is start from my left. And we can go in the order, though, I think that's on the agenda. But in terms of, to my far left, we have Dr. Atul Butte, who's down from the Bay. He's a professor.
We loaded the slides in the order.
Oh, we did?
They're on the program.
Yes, so that's what it is. So we'll,
forward
okay.
Go in the order.
Order in the program. Sounds good.
For,
yes, sounds good. Oh, no, thank you.
Go Siegel, Knuckles, Walling, Booth.
That sounds great. We'll do. But I'll start with introductions this way so we're not confused. But so anyway, he's the a professor, executive director of clinical informatics at UC Health, and the director of the Institute for Computational Health Sciences at the UCSF School of Medicine. And to my immediate left is Dr. Chris Siegel, professor and vice chair of the UCLA Department of Urology at the School of Medicine here, and a co-chair of this symposium. And then to my immediate right is Dr. Terrell Knuckles, vice chair and clinical research and director of the Division of General Internal Medicine at Cedars-Sinai Medical Center. And then to my far right is Dr. Ann Walling, assistant professor and staff physician in UCLA, as well as the VA Greater Los Angeles healthcare system. So I think then without further ado, I'd like to ask Dr. Siegel to come up. Actually, you can speak there if you prefer, or you can come up here, either way.
Well, I don't have any slides, so I'll spare you all that. So good afternoon. I'm Chris Siegel. I think today's session we're talking a little bit about the interface between value-based care research and the improvement of care. And I think my personal career arc has kind of mirrored where we're at today. I mean, I started out really interested in descriptive analyses, ran for a long time with Mark Litwin, describing quality, cost, and access of care issues in urology. But as I grew older, I wanted to make more of an impact with my research. I thought, as we discussed earlier today, that decision-making in healthcare is really a prime target to describe problems and to put implementation in to improve it. My area of research is around shared decision-making. And what we're doing now at UCLA is at the interface of improving care and also describing research around the results there. We use software to quantify patient preferences at the point of care. We've talked a little bit today about how the patient voice is often lost in this discussion. And so based on what I learned about describing quality of care problems, I felt that was an important implementation to bring into to use. And Kenrick and I work together on that in back pain, for example. We use it in urology quite commonly. We use that data as part of a decision analysis of the point of care to help patients make decisions in line with the evidence that's attending the decision and their preferences. And I think our learnings have been that doing this work is really complicated. As Dr. Fogelman said, we're going to have a lifetime of work in getting through local challenges and changing care, but it's certainly doable as we're learning. We're improving, we're measuring our outcomes as we're delivering the care. So that's just my introduction to what I'm doing, and I'm sure we'll have more in the meeting.
Good afternoon. I just want to congratulate Catherine Sarkissian and her team again on just a fabulous conference, and it's been really fun to reconnect and with people I've known over the years and to connect with some new people. So I'm going to talk a little bit about my work and then also some thoughts on implementation going forward and some of the things that we need. So I actually have some slides. So Paul Siegel was here a little while ago. I don't see him anymore. So we were working on a project for several years to try to answer this question: can improving quality of care also lower costs? So we're here talking about value, which is often thought of as quality divided by costs. And we handpicked a number of topics where we thought there was a really good chance that improving quality would lower costs. And I'm going to show you some results. We did systematic reviews of the literature. We started with 15 topics, but somebody else was pointing out earlier some of the dearth in literature and how we should be doing more cost effectiveness analyses in there. And we ultimately found that it was only feasible to do the systematic review formally on 3 topics. These were readmissions, glycemic control and diabetes, and CLABSI. And so basically we were looking for studies that met 3 criteria. They had evaluated clinical outcomes. They had evaluated the cost of implementation, which somebody alluded to earlier, that how much are we willing to spend on measurement and oversight. And then the third is what are the costs associated with any complications that were averted. So trying to not spend more than my 2 minutes here, but it's possible we'll go over a little. So we looked at hospital readmissions. You would think, hospitalization is very expensive. Preventing readmissions is a big national priority because it's so expensive, and they're thought to be a marker of poor health. So we looked at heart failure as well as readmissions in general. This just shows the heart failure results. 25 studies of QI interventions, pretty effective at reducing rehospitalization. But if you look at the net cost, this includes both the implementation or program costs and the cost of the readmissions averted. Cost neutral. I mean, if you can get better health and keep your costs the same, that actually is good evidence of value. But it calls into question the idea that there might be a return on investment for this type of intervention. We also looked at glycemic control and diabetes. So glycemic control and diabetes, you would think if you're looking at the long term, this would be the poster child where improving quality is going to save money over the long term. Dialysis is really expensive, heart attacks are very expensive, strokes are very expensive, amputations. What we found is, although these QI interventions were effective at reducing hemoglobin A1C, and in the short term, they were cost neutral, which again is good value. In the long term, because they increased survival, costs went up. And this is these are formal cost effectiveness analyses, and today people say the willingness to pay may be as high as $300,000 per quality. It's not the $50,000 in the US that has been talked about since the 1980s. And these all had a cost per quality of up to about $115,000. So again, good value, no return on investment. And then the third study, systematic review, we looked at interventions to reduce central line associated bloodstream infections. And these are fairly simple, checklists and, modest changes in clinical practice. So the costs of implementation are fairly low, and these are fairly expensive events. So the infections went down by about half in these studies, and the net savings to this hospital over 3 years were $1.85 million. So in this case, there is a substantial net savings that we're seeing with quality. I'm going to skip over the next one because I think we're going to run out of time. But I wanted to point out that when we're talking about value, a lot of times we're lumping together these concepts of quality and cost. They're very different concepts, and I think we need to remember that. So here, I don't know how well it's projecting, but we want to move from this lower value to higher value quadrants. And if the studies I just presented were to be categorized, you're going to see diabetes, increased costs, and increased quality. Readmissions remained cost neutral, which is again better value, quality went up, and CLABSI is down in this beautiful corner in the bottom right where we actually lowered complications and ended up with more money in our pocket. And I would just assert, this is my, based on my work in the field, I think that, fee-for-service incentives push us up. Somebody else mentioned this morning. We have this constant pressure upward in terms of the health system wanting to spend more money because that's where our profits come from. I'm going to think most quality improvement initiatives are going to be in the side on the right, where either they are a little bit more expensive but a good value, or they don't change costs. And the holy grail or the unicorn is down kind of in the right lower corner, where you're either reducing the overuse, and this is based on, if you use the appropriateness criteria definitions, where you can really say, this service is going to hurt somebody. That's going to save money, or if you have very costly complications. But I think we have to be cautious about saying that improving quality is going to save money. I think if we're going to move the field forward and we're interested in looking at costs, we need to look at these bottom squares here, where we're reducing the use of discretionary services that don't provide a lot of health value, or we're reducing potentially, one of the things that policymakers could do is they could reduce prices. That'll reduce costs, and it may also reduce utilization. I know we don't like to talk about that because profits, that's where they come from, but that is something that should be on the list. And then, just think about, can we use less costly services that maybe not are quite as good in terms of quality, but are almost as good? And that would go down over in that bottom square there. So you have to do these detailed analyses, really looking at what the indications are in different situations. People talked about the appropriateness method to figure out where things belong in this quadrant. So that's my my discussion of the research that I've been working on and kind of where I think things need to go in terms of value. I think the other thing from an implementation standpoint is where's our workforce? Where's our workforce who's going to be able to do this? National policies and private payers are really pushing for value-based payment. And when I rotate on residents on the service and the inpatient wards with residents, most of them don't even know the difference between Medicare and Medicaid, right? And so the degree of education that people are getting as part of medical school and residency training that prepares them to practice in this value-based environment is really de minimis. And I don't think it should necessarily come in the beginning in medical school because that's pretty full already as the science advances. But we have to think about how we're going to do that. I was talking to Bing Zhang, a UCLA resident, who was telling me that she established with some colleagues at UCLA, a track for systems-based practice in the residency, and I think that's very exciting. We have a new master's program in health delivery science at Cedars-Sinai, an executive-style program in the evening where people have the ability to learn about healthcare finance, quality of care, digital health, these sorts of things, and we're exploring the possibility of how do we integrate this into our residency program to give more people the opportunity to acquire these skills. So those are my thoughts, and thank you very much.
So it is truly an honor for me to be here today with so many of my mentors. Is Dr. Litwin still here? He was my first mentor when I was a third-year medical student. So, so I want to talk a little bit about my research. So, and I think that it's very unique that I've had the opportunity to work here in terms of with the Advanced Care Planning and Services Initiative here at UCLA. So as co-director with Neil Wenger with that initiative, I've had the opportunity to take what I've learned from my research and my clinical work and really apply it to improve care here at UCLA. So the vision that has guided my research to this point has been that palliative care should be the standard of care for all patients with serious illness. And the research that I've done can pretty much fit into two main buckets. The first bucket has been the development and application of palliative care quality indicators, and I've used the appropriateness methodology that we've talked so much about today. Some of these measures have gone on to National Quality Forum endorsement, and I have taken these measures and used them to help support integrating feasible advanced care planning and palliative care strategies in various different settings. So I wanted to take a minute just to give a concrete example of this work. So we've worked to develop a clinical model for the successful integration of palliative care within the oncology clinic. So our team consists of our advanced care planning team, and we work closely with palliative care and the Sims-Man Integrative Oncology Center, which is a psychology-based supportive care center for a cancer center. And we partnered with oncology. So from the oncologist perspective, they were interested in meeting unmet palliative care needs for their patients, but were often reluctant to refer patients to standalone outpatient clinics because of the concern for increased burden of an extra visit for these very sick patients, and also concerns about continuity, especially if you're going to be referring patients for palliative care early in the trajectory of illness. And so we began to meet regularly with oncology and together developed an NP-based model of palliative care, which was integrated within the oncology clinic with the goal of early integration of advanced care planning and palliative care. So we ultimately developed a shared mental model, which is a concept that we took from teamwork literature, that we supported with scalable implementation strategies, such as a structured referral mechanism, so that all team members understood the prognosis and treatment options for a patient. We integrated routine symptom assessment and management with specific triggers so that patients who had psychosocial needs had those needs addressed in a timely fashion. We were very clear about team roles and accountability, with everyone's priority being that patients' care priorities and preferences should really be leading the care plan. And we highlighted closed-loop communication so everybody always knew it was on the same page about what was important for the patient. And then an important key is to have real-time feedback of key metrics to encourage ongoing improvement and to always take advantage of opportunities to integrate palliative care skills training. And so through this approach, we were able to, for patients enrolled in the NP embedded model, we were able to show increase in goals of care documentation, increase in referrals for psychosocial support, which led to increased hospice use at the end of life, as well as decreased ICU and hospital use at the end of life in the last 6 months. So this is an example of how you can take the quality measures, take the science of quality measurement, and use implementation strategies in a way that's scalable across a health system. So in terms of my perspective of what we need to move the field of value-based care research forward, first, this is a little bit biased, but I think that palliative care is a key component of all value-based care. And to refer to what Dr. Knuckles was saying, I think that this is one of the areas that is in that unicorn box where we can improve quality as well as decrease costs in this population. I think we need pragmatic population-based studies and think broadly about how we can improve care for populations. Identifying the right population for intervention and being able to consistently identify that population across settings as well as across health systems. For example, there's this advanced care planning study that we're doing right now where we need to identify the same serious illness population at UCLA, UC Irvine, and UC San Francisco. And being able to do that in a way that is consistent and use that for future studies is going to be an important effort. I also think we need to be thoughtful and use innovative clinical models that use multidisciplinary teams, but think of tiered approaches so that it's not a one-size-fits-all approach and that we can really meet patients' needs where they're at and not provide too many resources, but provide the right amount. And then lastly, I think once we have successful models that work, coming up with, working on innovative partnerships with patients, payers, and health systems to make sure that there's a sustainable plan for the growth and spread of these types of models, I think is going to be really, really important. Thank you.
Great. I'm the last speaker here before we start some discussion. So my name is Atul Anand. I was supposed to go in the morning, so thanks to Liz for swapping with me. And I'm going to explain more about the central data warehouse that we've been building. Lots of conflicts of interest. All right. As you know, the United States has been spending billions of dollars on electronic health record systems. So I just showed three kind of news reports here. Sutter spent Sutter is our frenemy, I guess, in California. They spent $1 billion on their electronic health record system. Partners, which is Mass General and Brigham, spent $1.2 billion on theirs, and Kaiser spent $4 billion on theirs. Strangely, they all bought the same software, Epic, actually. So you can see the price can range. And obviously, it's more than just the software. It's the workflow, reanalysis, and all of that. But to me, as a kind of generalism here, I think the country has been spending billions, if not hundreds of billions of dollars buying these systems and rounding error close to zero using most of this data, right? I think that's the fun new challenge of what to do with all this data we've paid for. So my role when I moved here from Stanford about 3 years ago was to help really shepherd and build out this central data warehouse with the data from all 6 University of California health systems, right? So it's UCSF, UCLA, Irvine, Davis, San Diego, and Riverside. Riverside is the tiniest of the 6, right? But the other 5 do have NCI comprehensive cancer centers, and all 5 obviously have CTSA programs. Now, what we're talking about is a central data warehouse, so all that data moving actually from the component campuses into one central place. We could have never done this without the previous 7 years of work into Rex, right? So UC Rex has been there. Doug is here. Lucilla had a major role down at UC San Diego, and many others. Really, the teamwork that for 7 years, where these teams across the campuses, the IT folks, the academics talking together, working with each other to harmonize data elements, we would never have gotten anywhere without this prior work. And with that now, with the federated system where we've been always able to count patients on each other's campuses, now we can actually get to the data as well. But you can see the most impressive number here is we do have 15 million patients that we've cared for in the University of California system over the past N number of years. And if you do the math, 15 million is 5% of the US population. I mean, it's an impressive number of patients. I'll be the first to admit most of these patients just get a flu shot from us and never come again. But on the other end, it's the most expensive, complicated care in the world, right? Patients come to us when they're really sick. Now, the other thing I've learned in 3 years here is that we as academics, look, I write papers and grants. That's my job too. But we as academics have a certain level of volume in our voice. What really makes a difference is when you have a business reason to do this. And so the UC Health System announced, I think maybe Liz might have mentioned this or not, last summer, the partnership with United Health Group to make a single ACO, a single accountable care organization for the state of California. Now this is aspirational, right? Even in the press release, 5 to 10 year plan, but this is the goal. And the minute you've decided now to make a single ACO, you got to understand the practice variation, right? You do it this way, why do we do it this way? And all of those kinds of differences. And then all of a sudden you need a central way to look at that. And so that, to me, it's the business that really drove the creation of this here. This is proof that it's actually done, right? So we have a lot of this data. Now, I mentioned 15 million, but that's a total set. Now we're really working on more active ones, just the past 3 to 4 years. This is a geolocation of all 2.1 million active patients in the UC Health System, so 2 visits in the last 3 years. And each one of these little circles there, you can barely see, is a pie chart. It tells you which campus has patients in that particular zip code. So UCSF, UC Davis is in blue, UCSF is in green, yellow is UCLA. I guess you call that color teal is UC Irvine, or light blue, and then UC San Diego is in orange, and Riverside is obviously to the east of that. But you also see in Las Vegas is yellow, right? Because UCLA sees patients in Las Vegas too, right? We see patients all over the world. The Hawaiian Islands are covered with our colors, right? When they're sick, they really come to us. And we have all the race, ethnicity, as good as it is from triage and registration, right? I still admit 30 to 40% of our patients don't even give us that information. As another example, the UC Cancer Consortium announced last September that all the cancer centers were all going to work together now to try to get trials of the future, right? The entire system now can negotiate for trials instead of PI by PI on our campuses. And here are the 141,000 cancer patients we see a year. It's an impressive number, and same kind of geolocation there. Now I'm going to end with diving real deep into one particular kind of concept I've been thinking a lot of. Technically, I guess I'm an endocrinologist, so I think a lot about type 2 diabetes. It's already been mentioned a lot so far today, which is great. For those who are not in the field, this is how you're supposed to practice medicine for type 2 diabetes. This comes from the American Diabetes Association. These are the practice guidelines. It's pastel-y. It looks like it even came out of California, right? I mean, it kind of has colors we would use, right? And how do you read this, right? At the top, it says, as a doctor, you should tell them to eat healthy, lose weight, and exercise. Okay, no brainer. And if and when that fails, you go to metformin, which is the big thing at the top there. And if and when that fails, you got these 6 choices of colors, of types of drugs. And when those fail, you add the other 5 choices. And when all that fails, go to metformin and insulin at the bottom. So that's how you read these. So now, okay, simple question. Number 1, which of those 6 boxes do you choose at the top? Well, it says there, choice depend on a variety of patient and disease-specific factors. So it doesn't really give you much of a clue. Never mind, some of these boxes cost 100 times more than the other boxes, but they're all in the same size box here, right? So that's kind of curious. So kind of simple, naive question, what exactly do we do at UCSF for our diabetes patients? What exactly do we do? So I'm just going to end with a couple of these kind of rings. Think of these as pie charts. We used to call these diabetes donuts. We realized that would be inappropriate. So now we call these lifesavers, okay? That's more appropriate. So now, in this ring, you can, the way to read this here, if this works, you have 12,000 patients with diabetes in this ring here, okay? And the yellow means, so we go back to the first drug we can find that we gave to these folks. A third of them start on metformin. That's good. That seems like what we were supposed to do. A third are on insulin first. Oh, okay, interesting. A smaller bunch going on sulfonylureas, and then on and on and on. Some of these purples are very expensive drugs. And the black means there's so many slices there. I can't even show you all the colors, right? There's just that many ways of doing this. Now, I think of a lot, so I'm a computer scientist on the side now. I think a lot about how we practice medicine. It's almost like a game sometimes, not to belittle having diseases, but think about how we practice medicine. We make a move, and then we wait for the patient and disease to make a move, right? And then they come back and we make another move, right? It's very much like playing a game, like chess. So we've made a move here. Patient comes back in 90 days. This is our next move. Right? So the next ring are all the patients had to switch to something else. So yellow to yellow means they're still on metformin, but we had to change the dose. Yellow to some other color means we added a drug, subtracted a drug, changed a drug, right? So that's all the colors. You can see how many people switch or not switch. They go home, they come back in another 90 days. Here's the next move. All these folks that didn't have a second ring, right, they're okay on their dose, right? They go and they come back, and here's the 4th ring. And when you look at this carefully, you realize if you count all the spokes in this ring, you realize we have 1,600 different ways to take care of type 2 diabetes at UCSF, right? There's 1,600 ways to go from the inner part of the circle out. Probably ridiculous, right? Probably a little too much variation in practice there. Now, what's really neat with the central data warehouse and the model that really works well is to get something to work on your campus first in UC, and then scale to the central data warehouse. This is how it looks across the entire University of California, right? Now you see this ring has 71,000 patients with type 2 diabetes. And then you realize the problem's even worse. We have 6,500 different ways in the University of California to take care of type 2 diabetes. And you can just see there's some similarities here, but a lot of differences too. And you can see all those purples are the expensive meds here. And now imagine though, we have hemoglobin A1Cs up and down these rings, right? Every time they come back, we're certainly ordering and getting the measurements. It's beyond claims data, right? We have every dose, every vital sign, every lab test result, and all these folks. So imagine the future of doing comparative effectiveness of strategies, right? We can already start to see African Americans seem to do better this way. Asians go better this way, right? We can make our own pastel-y diagram with our data, right? Not just a bunch of experts, but with our data, what seems to work or not. I'm even going further. I'm trying to come up with new metrics. I can see hemoglobin A1Cs change, right? They're supposed to get better with these meds. But imagine a metric of a future of improvement in A1C per dollar, right? That's a metric no pharma wants us to compute right now. That's why we should do it, right? Improvement in A1C per dollar of how much the med worked, right? We have the power to do a computation like that. But in the end, we can also put fancy things like machine learning in this. This is my last slide. You saw those yellows, the metformin, right? And some needed something else, and some did fine with that first dose. Why don't we just put some simple decision tree, and forget about deep learning, simple decision tree. Green means you were okay, and red means you had to switch. And if your hemoglobin A1C was ever more than 8.8, or your fasting blood sugar was over 206, don't even start the metformin. We know it fails in the University of California. You're just not going to make it, right? You're going to need something else. So what's the move you were going to make in 90 days? Just make it now, right? Just get the therapy, get the effectiveness 90 days sooner, right? That's just with one choice. We can do this for all the choices. So imagine precision medicine to practice. You come up with a list of meds with our own data, right? This is hard-earned data. The systems have spent hundreds of millions of dollars, and to me, this is the most expensive data in the world, EHR data. We pay doctors to type this stuff in, right? It's super expensive data. We should be using it a lot more and feeding it back in this kind of decision support. So my open challenges, problems I think about, we can't really learn how to win these games if we're only playing with half the game, right? So what do I mean by that? A transplant patient, let's say at Kaiser, comes to UCLA for their care, lots of intense care, then they go back, right? So we got one half and they got one half, great EHR data. We don't really like to share that, but that's half the story. So we need a lot of that in the same type of database, along with the charges and the care. The second point is this what we're talking about here? Is this all just going to be about writing papers, or are we actually going to help a system? I know not everyone here is from the University of California, but can we do this to help the UC system? Or is it about both, which is great? And one of the things we talked about over lunch is as newer academic medical centers are starting to practice ACOs on their own employees, we have something called Blue and Gold, which is kind of acts like that. Those are us as employees signing up for us as a care provider. So to me, it's great to reduce costs. It's going to be more interesting to reduce our costs, right? Because we pay for that medical care for our own employees who sign up for our plans. And then in the end, I think we're going to have to learn what's valued and what's excessive in healthcare, even if nobody wants to fund this, right? And probably they're going to be, if we get better and better at this, there are going to be people funding things against us, right? And you know who the players are going to be. But we should be doing this nonetheless. So I'll sit down.
Okay, wonderful. So I think we're really privileged because we happen to have people from 4 different health systems here who are all researchers, and I would say really all are in leadership positions as well in their respective systems. And so I think, as I mentioned earlier, I want to really, we heard about shared decision-making and involving patients and maybe issues of workforce, how to get folks oriented at large to this type of orientation and palliative care, and then looking at what we're doing now and the sheer immensity of different ways people feel is optimal currently that we know don't have the value that we'd like to see. So I guess thinking to each of you, those who'd like to answer, really practically in your system, in your setting, thinking about your work, other high quality work in your field, what are the next steps where we are on the ground to really push this value-based care agenda forward? So.
Go first.
Sure. Well, I think, certainly in the field of decision making, and I think one of the critical things is how to measure what a good decision is. There is not a standard definition there, but it's something we do as physicians all the time. And if you think about it, how do you know you've made a good decision? Are you guideline concordant? Have you met the patient's goals? What's the patient's satisfaction? Those are things that have to be defined, because if you can't measure a process, you can't improve it. I think at UCLA, we have our basket of measures. We look at not only the patient's decisional confidence after making a decision, which has gone down after our interventions, but also things like Net Promoter Score, so the patient's willingness to recommend this doctor to another patient, because I think that physicians have to be incentivized to participate in high-quality decisions as well. You have a win for them, and we've seen improvements in Net Promoter Score in our department. They've doubled, actually, and other departments as well. So I think that the measurement paradigm for decision quality is important, and incentives, I think, matter a lot. So those are 2 things, the correct incentive structures and the decisional quality framework.
One thing I think that is a really important key is partnership with clinicians, and having clinicians really be very engaged in the process of how you're going to evaluate and how you're going to improve. One of the things that I've learned from working with oncology is that they have their leadership and their guidance is what leads to the success of the interventions. And so one of the opportunities in working with this pilot, when we started, we were only working with one oncologist, and we've expanded that to more oncologists. But we've also had the opportunity to use the metrics that we developed to evaluate the quality improvement effort to now feed those metrics back to the oncology level. And so to be able to do real-time quality improvement in a partnered fashion, and not just feedback metrics and ask for them to be improved, but also try to think of ways that we as a health system can provide structures to make it easier. Because there are barriers and there are reasons why it's hard to have these goals of care conversations in the clinic setting. And so having sessions to teach oncologists about how to use the new advanced care planning billing codes and how to use help working with us to develop a goals of care template that works with their flow. And these types of supports can make this actually feasible and useful, and improve healthcare, both primary palliative care as well as specialty palliative care.
I guess I think that keeping the stakeholders informing the process, I think, is really important. I worry about the burden that we are placing on frontline providers with all the quality measurement and the documentation, and how do we accomplish our goals and make it easy for them to participate in this system-based practice, I think, is a really important issue. And how do we facilitate measurement in a more precise way? I mean, I was just talking about the appropriateness method. Other people have been talking about that, but to do an appropriateness study takes few $100,000 just to develop the measures, let alone, doing the chart review to really figure out, which bin different patients go into. And we can't do that as part of operations. So I think, there's a lot of, pragmatic issues. How do we balance these things and make it easy for us to measure what we want to measure and not overburden the system in the process?
I guess I'll answer briefly too. So we're doing a lot going on at UCSF as well. I'll put on a UCSF hat first. I think certainly we have dashboards. Everyone's got dashboards. I think we're starting to think more about predictive analytics. So not just what is the readmission rate, unexpected readmission rate, but who do we actually think is going to get readmitted? Putting all the tools we can, deep learning, partnerships with tech companies in a safe, responsible way. All of those things are certainly front of mind right now. I think people have mentioned the quality of data in the EHR. It is the legal record now, okay? And it's probably not going to change for a long time. We've spent billions on these things. We're not going to change that. So we're going to have to get used to using that data, warts and all. So I think we're going to build more automated tools. Whereas those tools might have existed for decades in the claims-based world, we're going to need to figure out even basic tools for the EHR side. For the diabetes example, so diabetes is a great example of a mix, right? Where we have some care in the specialty side, but a lot of it's in the primary care side. Very different metrics, different guidelines, different even attention to details. But I think a lot of people have tried to improve diabetes for a long time. Well, one thing we can think about is clinician-specific benchmarks now. I think we're used to hospital-specific benchmarks and site-specific benchmarks, but I think we can get down to a specific clinician, and exact cases, right? You used this expensive drug 3 times in the last month, and your peers did not. We could already start to see that these clinicians knew they were practicing differently. They had no idea they were that differently. And just to give you one example, there's one clinician who said, well, he had been trained to start patients on as many drugs, like a whole bunch of drugs at the start of diabetes, and then peel them back, right? Which could be a rational way to do it, right? But the opposite of that graphic, right? Technically, start with a bunch, hit them hard, right? They would say hit them hard, and then kind of peel back the drugs. And that's how they were trained, right? That's how it is. So I think, but visualizing clinician-specific guidelines might be interesting ways to proceed.
Okay, so I think we're open for questions from the audience. So we have the 2 microphones. Please introduce yourself and tell us where you're from before you ask your question.
Hi, I'm William Dale from City of Hope Cancer Center. My question's for the EHR. We just went through our own EPIC experience in many ways a few months ago. My question is about the sort of speed with which these things are happening. So City of Hope prides itself on, taking it from the lab to the patients very, very quickly. And so early adoption, patients are coming there for that. So in guidelines, of all things, are one of the slowest processes. Having gone through a guidelines panel, it takes a year, year and a half just to get something that we all think is appropriate and evidence-based. So this challenge of sort of this data that is always behind in some sense, but we're relying on it to guide our care, and the evidence is falling further and further behind. How are we going to deal with that issue?
I mean, I don't have an answer for everything here, right? But I think, so one of the things, I mean, it's really nice, at least in one area where UC seemed to step ahead, is that we're in optimization phase right now for Epic in general, except for Irvine. I think the rest have had Epic now for 3, 4, 5, 6, 7 years, UCLA even longer. So we get to start to play with the data instead of going through all the pain that partners, Vanderbilt, all the rest are still now all of a sudden putting in Epic. So we get some luxury there. Guidelines, right? So I think guidelines, expert-driven committees and Cochrane and all the rest of these are ways to come up with guidelines. But I think in some ways, look, our guidelines are the right way to go here. I'm not so sure anymore. I think, to give you an example, I think, let's just pick on the industry that I used to use a lot of drugs for, let's say the diabetes or the, anti-hypoglycemic drugs. A lot of companies shoot, their best case scenario is get a drug that's non-inferior, right? So it might be 100 times more the price. Maybe side effects are better or not really clear, but non-inferior. They don't want it to be, certainly it's okay if it's not better, it shouldn't be worse. And I think, and pricing, I think, is really crazy. I want to start to study more of our drugs in our own patients. In reality, it's really kind of astounding to me. I mean, over the last 3 years, I realized in general, after drugs are approved, nobody seems to study if they work in their patients. That's stunning to me, actually. We just use them. Patients ask for them, and payers, and we just let PBMs and stuff dictate what we use. So I want to study more of what works and doesn't work. In particular, I think where we need to do this more urgently than not is a set of conditions that no one seems to have mentioned so far today, which might even be the opposite of value-based care. I'm not sure, is rare disease. I'm not sure what we're going to do with rare disease. I'm not sure the value-based way to do that. We have 3 drugs now, over $700,000 a year. I think there's just a mental barrier at $1 million because they could set it at $1 million. Nobody could do anything differently right now, those companies. So I think we should not just take it as a given that a drug is approved and that it's in a guideline. I think we should continually study whether they actually are working. And I guess that's what some people would put into a learning healthcare system.
I could add to that. I think that's interesting that guidelines don't typically include patient preferences, which I think in practice is a source of great misery for some of us. And but I think now we are at the point where we can collect those preferences at the point of care. We're doing it at UCLA. We're integrating our software now within Care Connect, so those preferences will be recorded and referenceable to third parties or to our own physicians. So we can do better than just guidelines. I had a question for you, Atul, in terms of using EMR data to study like post-release effectiveness. There's obviously, as you mentioned, a lot of provider variation in terms of who gets what. So how do you correct for that when you're looking at the outcomes? Because obviously patients are being selected for these medications.
Yeah. So just a quick answer to that. So certainly not all panels are equal, right? So I think Alvin Rajkumar, who published a paper from UCSF now, he's at Google on the brain team, just using deep learning to try to equalize and normalize even panels and how complicated they are in the primary care setting. You can imagine doing that on the specialty side as well. So not all are equal. I think it really depends. I mean, what you do, it depends on what you're going to do with the answer here, right? If you're going to study, you come up with this kind of cute metric of an A1C per dollar, I think you might put in a couple covariates in there, try to build a model. If you're going to actually, promote or punish a physician, I think you want to go a little bit deeper, I think. So I certainly think. So people say there's noise in the EHR data. There's no doubt about that. I wouldn't say it's noisy. It's just that is the record, right? You can print out that record and put it on a gurney and transfer a patient with that now, right? It's not going to get any better. But just to kind of make a real quip about it, at UCSF, we have this incredible cohort of patients we've learned that are incredibly short and incredibly wide, because we keep putting the height where the weight should go and the weight where the height should go, okay? So we know these errors are there. We keep making them. Yeah, we can fix these, right? We can see them, we can fix them. It's not like it's not fixable. And the more we use this data, probably the data will get better, right?
Great.
But right
Thank
now,
you.
I don't see a lot of docs seeing we're doing much with that data. Right?
Thank you. So I believe you were up next.
Thank you. Hallie Chung from UCLA, and I'm hoping you can comment on the utility and value of participating in external clinical registries, such as the American College of Surgeons National Quality Improvement Programs.
I mean, I think that we in urology have our own registries that we're using, but I think the issue with external registries is really around the cost and the cost of data you get, and whether we can do something similar, a lower cost internally, and have it be more relatable to us. But there's obviously NISQIP's been an incredible improvement tool nationally, so it's mainly a dollars and cents things right now.
Okay, can I just put another quick, people understand the cost. I was looking up our numbers here. So at UCSF, we're in a bunch of registries. We're in 34 registries. 13 of them get central support. I was looking up our numbers. And just so people understand, we've done all our numbers. It's about 1 FTE per registry. So we have about 13, between 13 and 15 FTE, if you add up all the counts of people who just deal with these registries right now. That's kind of crazy. So cost effectiveness of registries themselves is questioned. 5,300 hours of data abstraction per year spent on registries right now at UCSF. We need computational tools to do this.
Hi, I'm Megan Neckerbecky. I'm here at UCLA. I think we've talked a lot about a big component of value is cost, but I feel like we're not talking enough about cost transparency, both for our patients and also for our providers to be able to really have that value decision and conversation with the patient. I hear stories constantly from folks who, elderly parents are paying $2,200 a month for health insurance, and just how unaffordable healthcare really is at that patient level. And I really feel like we're the stewards of those healthcare dollars, and I feel like we're not doing enough around data transparency. So I would just be interested. And also, I used to work for Dr. Skutsky, and so I know how much our healthcare costs when every time a patient goes to the ER or gets admitted. And I think most people don't know how much that costs. And so I'd love your guys' thoughts on how we integrate cost transparency.
I think it's a really good question. I know there's people in this room who've looked at that question. I think one of the studies that I've saw that was very interesting, basically patients saw cost as a signal of quality. So they wanted to go to higher cost providers, not lower cost providers.
One thing that I can just say also just about cost and how, this is probably obvious, but one of the things with the embedded palliative model that we noticed is that, the way that things are billed, the patients have to pay a copay both for seeing the oncologist and for seeing the palliative care provider. And so while clinically it seems very integrated and part of the whole same system, sometimes they had to pay $2, $50, $60 copays in one visit, which could be a barrier. And some patients, that was the main reason they didn't want to participate in the palliative care program. So one of the ways, and this is a good example of how we can partner with payers to come up with alternative payment models to really promote high quality care. So if you could come up with an alternative payment model that would support clinic-based palliative care that's integrated as part of the system, you could, avoid copays and that sort of situation, which would help growth and spread of these types of models.
Great, thank you.
Hi, my name is Michelle Hickey. I'm from the Department of Pathology, and I'm a laboratory director for immunogenetics. And our laboratory provides support for transplant services and transplant centers within UCLA, but also outside of UCLA. And many of these transplant centers or these other hospital systems also have Epic. And so I've always had this vision of like one Epic, and always thought, well, I have Epic on my desktop. Why can't I just open this patient from another UC system in my Epic and see them the way I can my UCLA patients? I was just wondering what the vision may be for one integrated Epic across the UC systems, and then maybe even integrated Epic in between other tertiary or other centers where we might have other patients, so that we could see all of their information if we needed to.
All right, so shall I answer? So the first one's easier. So a shout out to Chris Longhurst, not here at UC San Diego, where UC San Diego, Irvine, and Riverside are all on the same instance of Epic.
That's great.
And then the other three are each on their own, for better or for worse. There is Care Anywhere. You can start to see the crudest of record that the patients can see when they go into their portal, so it's not zero. That's kind of, to me, how Epic gets viral, because the patients see their records and now everyone else needs to see their records. So I think in some ways to do that well. Epic does, again, giving credit in some ways, Epic was part of our initial pilot of how we're doing this. They're now rolling out a product called Constellation, where health systems would pay or opt in to put their data into a central place. What that exactly means is not crystal clear yet, but that could be there. It's not necessarily going to be as like they're a patient in your own system. So that's a long answer. Let me give a shorter answer. Okay, and that's a little cynical, and I'll turn off my optimism gene here for a second. I don't think we share data to the way you're thinking of, because we compete with each other. Okay, and just to be blunt, so if you're in San Francisco and you're heading to Oakland or back, in the middle of San Francisco, the last billboard you see before going on a Bay Bridge, or the first, Liz is laughing, is the Stanford billboard in the middle of San Francisco, right? Because they're competing for our patients. Now we are staffing Dignity Hospital in Redwood City, right on their border, right? So we compete for patients. Would I say we're so pure and beyond that if we saw a flaw in how they're delivering care that we wouldn't put it on a billboard? I'm not so sure we're that flawless, okay? Or they're that flawless. So I think we don't share because there is sensitivity in this data in the business world, right? And I don't know, we have to think of business models to get us to share. I think in UC we have one now, right? How to grow broader and beyond UC is a tough business problem. It's a way to think about it.
Thank you so much.
Great. Eve Kerr from U of M. That's very helpful also to hear the context of what everybody else is doing. My question, so I'm intrigued by the diabetes model that you put up, and you said, you know, you could do the flip of that, which is the de-intensification. I talked a little bit about de-intensification in my talk, and you know, I've looked for de-intensification algorithms. So the ADA, like you pointed out, has that very nice intensification algorithm.
That's right.
But there are, deepprescribing.org, which is a Canadian site, has a little bit on that. They're starting to do it, but otherwise there is no evidence-based de-intensification algorithm. So I would love to see you kind of replicate that. I'm going to go back and see if I can do it in the VA also. But the other part is de-intensification trials. So we really are at the infancy of doing de-intensification trials, and I wonder if you could use the UC system to do that. Yeah,
that's great. I think you would need to pick the right kind of disorders. First of all, big fan of what you guys are doing. We recruited Julia Adler-Milstein. She was on at your campus, so she's at UCSF now. So, and I was on your campus giving grand rounds. I was there 2 weeks ago at Michigan giving grand rounds, and so they've seen the diabetes donuts there too. I think it could be done. I think you'd need to pick the right condition where de-intensification is a common practice. It could be chemo. It could be you know, certain like early stage breast cancers, things like that, where you could really try to study that. So we'd have to creatively think of it. It could be diabetes, but I think most seem to follow the right path. It was a rare, you know, bird that went the other way, but it could be done. It could be studied.
So I think we have time for one more question.
Great. Adam Shard from Kaiser Permanente, and this is great and very exciting work. It's great to see others conglomerating all together and seeing the difficulties of 1KP, as we like to say, and that all one UC, if you will, is not exactly as it may, we all hope it to be. And I guess this is a comment. I'd love to hear what you have to say. I loved the comment about cost transparency. I think as we talk about disruptive innovation, if there's something that we are going to do, one of my things about, you know, Kaiser is obviously we're all competing. I think if we're going to compete and cost transparency is there too, I think the outcomes transparency as well has to be there. Obviously there's some things we're forced to report, therefore we can do pretty well on them, and it's hard to tell, you know, what's what. But I think as we come together, the one analogy I have in my mind that I love is I love David McCullough. I'm reading his book on the Wright brothers. I think it's a perfect example right now. If you haven't read it, I'll put in a plug. But the Wright brothers, they cared about learning to fly. That was their mission. They didn't care who really heard about it. There were others, the pillars, the researchers, the ones getting the U.S. government funding, Langley at that time. He cared about something other than flying because he didn't want anybody else to know about it. He didn't care about sharing. He didn't care about what that. I think those of us in this room, we care about improving healthcare quality and healthcare value. We know that costs matter, but we work for institutions of which they don't want to play in the same sandbox. And so I think that's a challenge for Kaiser. I think it's a challenge for UC, Cedars-Sinai. I mean, it's I think radical transparency, I think, in both of those venues is something we need to advocate for if we truly care about improving health and doing it in an affordable way. And I think that's something that each of us need to fight for in our own institutions.
Yeah, I mean, it's a great point. I think, I don't know how to respond to that. I think that's why I was kind of suggesting that if we're going to go after costs, go after our costs, right? I mean, there's a national cost, a national system, but you have to take care of the care of your own employees. We have to take care of our own employees, and in some ways, that's a dollar that everyone's aligned on, right? The health system CEOs want to save money, and we're learning how to do this, and we could teach each other how to do this in a more efficient way too, as well. But beyond costs, though, if we can pick excessive care that's bad. Not just costly, but also bad for patients, right? It harms patients. I think those are no-brainers. And I think, I don't know. I think we're all in a room together to share and to teach, right? I think we can do that and still be, in a non-competitive space, right? I think a huge non-competitive space here.
I'd say two comments on that. One is transparency is always a good thing. I'm not sure the consumers of healthcare know how to use those dollar values. What are they buying for that? You have a discussion with the patient about the value of an MRI that cost $2,000 extra. It's not so easy for us to understand sometimes. So there is that risk, I think, of giving them more anxiety. But your other comment about the Wright brothers, I think, is really a great place to end this discussion, because I think Catherine Kahn and I were having a discussion last night about sort of value-based care research can help us all to reach our highest professional calling. I think we're all here because we deliver care and it's important to us, but we also want to change the system we work in. That is a way, I think, to prevent burnout. And I think only people like us can actually make this happen, because it's a very complicated system. And we have a lot of insights about how this happens on a day-to-day basis. So great way to end the discussion. Thank you.
Okay, great. So we have one more question.
Oh, one more. I was so intrigued by all the conversation. I mean, it's an amazing panel, amazing conference, and lots of talk about the EHR, so I have to say something. My name's Mike Pfeffer. I'm from UCLA. And the one epic is a great question. Data sharing is a great question. We have interoperability beyond what anybody dreamed of, say, 5 years ago. We share at UCLA over 3 million records a year. But we will never get to one epic, because it has to be even bigger. So I'm going to make a statement, then I'm going to ask a question to the panel. If we really want to think big and totally think about what EHR 2.0 is, it's going to be that the patient's medical record is stored with the patient. Blockchain, you probably heard about blockchain. These are new ways that we can give the patient the medical record, and when they come into your health system, they authorize you to write to that health record. So there's one medication list, one problem list. We will never complete the story of the patient the way we are now. And in order to do that, we're going to need one patient identifier, right? So we will continue down the same path of EHR land and not completing the story until we get to the next level, which is totally transformational. So my question to the panel is, in order to accomplish really what you're trying to do, what is so big and inspirational that has to happen for us to take it to the next level?
Any takers?
Maybe the failure of the insurance system. I don't know. I mean, basically, it's going to be, we're heading an unsustainable path. And certainly the changes in the last few years policy-wise haven't been very helpful, I don't think. So that could be a catastrophic event that could potentially, roll on Bitcoin and blockchain. I don't know.
I love everything you say, right? Of course, and you know. So, but I'm gonna. But blockchain, forget blockchain for a second, okay? So, I think you still had to remove this competitive nature, right, of our health system right now. I think if you magically got rid of that, I think a lot would fix, and whether it's single payer or whatever, right? But because I don't think what worries me, again, I'm the optimist, right? So what worries me is none of the current players, right? So my worldview now, and I don't want to end with this, is like this triangle where I have pharma and devices in one corner, providers in one corner, and payers in the other corner. And strangely missing from this triangle are patients and businesses, right? So if you subtract that defense, VA, Medicare, Medicaid, businesses pay for the rest of healthcare. But individuals are powerless because they have a very hard time agglomerating, right? I know there's support groups for patients with diseases. I know businesses are trying to get together. Everyone makes a big deal of Amazon, JP Morgan Chase, and Berkshire Hathaway, and these kinds of constructs. But in general, they're powerless. They're acting by themselves. So then all you're left with are the folks in the triangle. And right now, no one in this triangle, if you actually ask the leadership, nobody in this triangle wants the prices or the system to cost less right now, right? Payers make their margin. We have revenue. We report revenue. The UCs and all of us report revenue. And pharma devices don't even start with how much they're doing with pricing right now. So I think you need a magical meteor to hit, right? That really, I don't think it's going to evolve to something better for the entire system, right? I think it's going to have to get replaced in something, because the competitive nature right now on this, my triangle, nobody in this triangle, it's a feed forward loop going up right now. And again, I'm all for empowering patients, but I'm not sure that's going to magically fix this though.
I love those points, and I'd just like to build on it. I think, you know, having done policy research for many years, I think we also have to think about politics. So politics is really where the decisions get made. We can do very interesting and informative studies, and nobody looks at them or implements them. And the people who are making the laws are all lawyers, right? Most of them are lawyers. How many people in our political system are trained in healthcare at all? Very few. And so I think we need more people who are clinically trained, who are willing to run for office, who can tell people a little bit more about like what actually is going on.
I wanted to make a positive statement.
We shouldn't end with negativity.
That
I'm going to vote for Anne first.
I have been doing research in palliative care for many, many, many years, and advanced care planning, and I've felt that was such an important thing because it was providing patient-centered care that really met the needs of the patients and families. And I've noticed over the past 5 years a growing interest in that work. And so to me, that's a positive sign that the way that things are moving in terms of population-based health and accountable care organizations, that we're moving a little bit away from the fee-for-service type system, and that we're actually moving towards an environment where that value-based care is valued. And so I think that I see it as positive that that things are moving in a good direction. So.
It's always good to end on a positive note. So if we could just have a round of applause for our panelists.